Today we have a very special fireside chat called One Nation, Many Islands Policymaking in the Philippines. So my name is Rie Tai. I am part of the Asia Dengue Policy Working Group, and we will be hosting this fireside chat. It is in person, but also we have a online viewership as well, and we'll be recording the session just to let everyone know. So before we start, just wanted to do a quick introduction about the Policy Working Group. It was set up last year in partnership between EquiHealth, which is a nonprofit arm of Vista Health, and we partnered with ADVA to set up this Policy Working Group. The Policy Working Group, we aim to achieve WHO goals of reducing or removing zero dengue deaths by 2030. Our aim is to prioritize dengue in national and regional policy making to ensure we're securing resources and raising awareness and unifying different stakeholders to ensure that policy is prioritized for dengue, and establishing community engagement through diverse stakeholders, including government, academia, community, nonprofits, and industry as well. We look into dengue-specific areas across vector control, entomological surveillance, patient surveillance, vaccines, dengue management through diagnostics, and also patient care management as well. Just to highlight some of the few things that we have been working on over the past year, is since establishing in April of 2024, we've been attending several conferences across the APAC region to present some of our key findings, which is now then in a policy map, which was launched in March of 2023, and then recently a white paper last month where we launched a policy recommendations based on the findings of the policy map. So the recommendations include how regional stakeholders can work together, such as developing a information sharing platform, also where dengue task forces should be built at a national level. So this white paper can also be accessed through our website from the Asia Dengue Policy Working Group website. So today, and just to illustrate here, so the policy map is a very comprehensive map of assessing different policies across from vector control, surveillance, vaccinations, across 10 countries in Asia. It is quite long, but we also have summary slides for each country, so I would recommend viewing this document as a baseline to understand what is the current landscape of different policies across dengue. And with that, we developed the white paper, which then can be accessed through this QR code or just on our website. With that, I'd like to introduce our moderator and panelists today. Our moderator is Dafa Green, who is the Senior Director of the Policy Working Group. And we have Dr. Eric Tayag, who's the former Undersecretary of the Department of Health and also the co-founder of Philippines Foundation for Vaccination. We also have Professor Tiki Pengetsu, who's a visiting professor at the Yung Lu Lin School of Medicine at NUS, and also the former Director of Research Policy and Cooperation at the WHO. So I'll hand it over to our moderator to again announce our panelists.
Fantastic. Thank you so much, Ria. And I would like to say to the audience as well that if you've never been to a Silver Jubilee of something like the Philippines Foundation for Vaccination, it's an absolute hoot. It was very, very good fun to celebrate the 25 years and see where the organization's got to. So yes, thank you so much everyone for attending this. This is the second in our series of country fireside chats at Asia Dengue Summit. We had Malaysia last year. Very interesting conversation with Dr. Ami from Institute of Medical Research in Malaysia to talk about some of the approaches they're taking there and some of the more country-specific policies that are being enacted. And I'm delighted this year that we have such an international audience with us as well. So nice to see friends from Bangladesh, Oman, India come join us and really see this as an opportunity for discussion, for sharing, for dialogue, and to see how we can all learn from one another about good evidence-based policy making to control dengue. So with this, I'd like to invite, is it Dr. Tayag? Yeah, Dr. Tayag, just to share a few reflections on dengue policy making in the Philippines. And so, yeah, over to you.
Thank you, everyone. Thank you, David. Good afternoon. I'm Dr. Tayag. I was with the Department of Health for the last 35 years. In fact, I had a publication on the dengue epidemic in 1998. Okay, and that epidemic coincided with the El Nino season. And knowing a year later that most of the Southeast Asian countries had similar outbreaks, the dengue policy has not changed for many years now. It is focused on vector control, the so-called 4S strategy. It's similar to the line of defense. So the first S is search and destroy mosquito breeding sites. So if we fail on this, then the second S is self-protection measures. You avoid bites from mosquitoes. And the third S is if you're bitten and there's an incubation period, you should be aware of the symptoms. So you have to seek early consultation. And of course, for large outbreaks or to prevent such situations, the last S is supporting spraying or fogging. And these are measures that are available for all local government units. A backstory about this is that you will never find an actual written policy on the 4S strategy. I just thought about it. And it has stayed for so many years. There have been many modifications, like there was a 5S, now there's a 4 o'clock habit, but essentially it involves those lines of defense. But of course, it doesn't include other tools for fighting dengue. Except that in the Philippines today, I'm proud to say that there is a coalition called End Dengue. END stands for Empowering Networks to Defeat Dengue Coalition. So it's a coalition of the public and private sectors.
We were all taught the hand signals by Prof. Bravo yesterday. Yeah. So is it 5 pillars, 20, action by 2030? Yes. And thank you so much to Dr. Tayag. Maybe I'll sort of before we.
Yes, thank you. It's a pleasure to be here. I probably bring a slightly different perspective, not so much at the country level, but perhaps at sort of more of a global level. I worked for the WHO for 13 years, and that was when Dr. Gro Harlem Brundtland was appointed Director General, and she created a new division, and the name of that division was Evidence and Information for Policy. So my brief in my 13 years at the WHO was really to work with the member countries to sort of say, whatever policy you do, could be dengue, could be malaria, it could be any other disease, it should always be based on evidence. And so that's what I did, sort of mostly in lower and lower middle income countries. And just like networks with dengue, we created a network in about 25 countries called Evidence-Informed Policy Networks, okay, dealing not just with dengue, but dengue certainly in some countries, it's one of the things they deal with. So since retiring from WHO, I'm now at the National University of Singapore, where I actually teach a course on evidence-informed policy and practice. So subject close to my heart. I'll stop there for now and perhaps later on share some of the more global experiences, not specific for dengue, but just finally, you mentioned Rie, one nation, many islands. It's not just the Philippines.
Absolutely.
I come from Indonesia, one nation, 13,000 islands. So we have a lot of common
We're just over
similarities.
half of what you have, 7,001. I think they have updated the numbers. Yeah, and we want to make sure we don't lose even one island.
I've heard that these numbers change with the tide. But no, yeah, thank you so much, Prof. Tiki. And yeah, absolutely, I think moving to this topic of how we develop effective policy based on evidence is something that I think is a topic we should move on to as well.
Well, I can share about that
Oh, please,
evidence.
why not?
Yeah.
Let's dive in.
Yeah, there was an outbreak in the Visayas, in Iloilo. But we first visited the Negros Island, and you can have a 2-hour travel by sea to reach Iloilo from Bacolod. And I was curious because when I asked the doctors that were taking care of the patients, I asked them, you are not using the WHO protocol on dengue management. Can I know why? Oh, it's so complex for us. So what do you mean? Oh, there are so many algorithms. We actually don't have time to memorize them. And so we just got stuck on what is practical. And so on our travel to the other island, I told myself, can we have something similar to the control of diarrheal diseases or control of acute respiratory infections? So my idea was, should all dengue cases be in the hospital? Then I said no. And what will tell someone, a physician or a mother, a parent, that this child who is suspected to have dengue should remain at home or should be brought to a hospital? And so we gathered in experts and decided on this. It was a week long, and they reviewed evidence. And so we came out with a simple algorithm, those who can be managed at home and those who can be managed in the hospital. Also asking the question, should all be given blood or blood product transfusion? So these were all based on evidence. And because I was the convener, I asked the experts, what do we have now? Yes, you can send this to the Secretary of Health, and this will be the clinical management of dengue. We have standardized it based on evidence. But I have one remaining question. What it is, Dr. Taya, we have reviewed all the evidence, we have all the journals, articles, we discussed it. Oh, just one final question. If it was your child, will you use this algorithm? They said, yes, okay, I'll now give this to the Secretary of Health.
Yeah, I mean, if I could just add to what Eric said, I think basically his comment that they find it difficult because there are so many other factors to follow a policy or a guideline. And in my experience working with policymakers in many different countries, no policymaker wants to make bad policy. It's obvious, right? But the main issue is that evidence or science is only one factor. They have so many other issues within the policymaker's pie, if you like. You know, resource availability, political exigencies. If they're a member of parliament, when is the next election? Okay, media, lobby groups, interest groups, culture, religious issues, etc., etc. So I'm a scientist by training, but after being exposed to the policy world, I actually sympathize with the policymakers, and some of them are, of course, politicians. Okay, so it's tough for them to make policy because they have to balance so many things. And there is a saying that what is right is not always popular, and what is popular is not always right. Okay, so if the election or their re-election comes up in 6 months, that's what's in the back of their mind. Stop it.
Reflecting on this in the Philippines, I've had some very interesting conversations this week. For example, with somebody from Mindanao who was saying that the situation with dengue seems very, very different there. The experience of East Coast, and and conversations with Cebu from Palawan, etc. All and it seems with that decentralization that everyone does have a little bit of autonomy in their own decision making. Is it challenging for the planning to kind of try and navigate this and find a compromise between everyone, or do you think it's one of those topics that is so kind of clear cut that it's
Okay, if we are going to focus on on communicating dengue messages, for example, there's a Health Promotion Bureau, the Department of Health. It gets technical input from the Disease Prevention and Control Bureau, which has in its own bureau a unit dedicated for dengue and other vector-borne diseases. So what happens is that there is a core message. Okay. While you mentioned that decentralization, or we call it here devolution, so this seeps into every area in the Philippines, and these are now localized. So it's just a menu, for example, just like you're in a restaurant, there's a menu, and each one can choose which fits them culturally, geographically, and what is feasible and practical that they can actually implement with ease. So that's what happened. So while there are more than 7,100 islands, there's a core message. It goes through all the areas, then they localize.
so almost like a
Yeah.
a la carte
Yes, and
menu for policy.
yes, because we have different languages here. So many languages. Even a province can have several languages.
That's exactly the same situation in Indonesia. We decentralized our healthcare system 40 years ago. And, the big problem with Indonesia is the lack of capacity in some of the more remote provinces. But at the end of the day, I think the most important thing, as Eric said, is how you communicate those messages. We have 200 different languages, okay, and many in the remote areas don't even speak the national language, so it has to be in the correct language. Not those that didn't go to school.
Well, like your story, I think of, was it COVID vaccination?
Yes.
Having local leaders speaking their own language.
Exactly.
Yeah. So this central message that then cascaded down, do you do this in consultation with regions to kind of test the message?
Yeah, for example, there's the marginalized group, the indigenous people. So we would go to this place, talk to the mothers, explaining to them, but nobody would even take a decision to have their children vaccinated.
Yeah.
They all point out to an imam, the leader of the tribe. So instead of speaking to each mother, you just speak to just one person.
Yeah.
And if you're not able to convince him, there's no trust, all those mothers won't have their children get vaccinated.
Yeah.
So you really have to know the culture. And there's another culture, for example, those living in high fences. So when we do our mass immunization, the feedback we get is that in flash subdivisions, most of the vaccinators are not welcome. They would just say, oh, our private pediatricians just said that we don't have to have our children vaccinated again. And so we actually communicate to the medical societies so that it trickles down to their members so that they are aligned with the national policy.
I think this takes us on quite nicely to the topic of trust. And I think COVID is a fascinating period for us to reflect on. For, even though I don't live in the UK, reflecting on Boris Johnson having COVID and being hospitalized, I think that for a time had an excellent impact on political trust and the commitment towards vaccination. But then it was obviously unraveled in other areas where they were a bit irresponsible. But just more broadly, I feel, I'm just speaking for myself here, Dr. Tai, that the way you communicate, I really, really admire. And I think that's one of those approaches that really does infuse enthusiasm, some humor, but has a really strong underlying
David,
message.
you can just imagine me with the Cebu inmates dancing,
Exactly.
dancing the dengue. I was trying to simulate the mosquito motions, and I had to do that. And of course, when the Secretary of Health and I visited areas to promote the forest strategies, someone would shout, "Secretary, please come over our yard. Can you clean our clear and stagnant water?" So, while our promotion was for each family, each household to do their responsibilities, their roles, everyone wants the Department of Health to do it for them instead. So, but what we wanted is that to empower each household.
Yes.
But what the households want was for us to give the services instead.
Yeah.
I think even the way you approach the communication is particularly important. During COVID, when we were trying to, in Indonesia, to try and convince, let's say, a particular village to take up the vaccine, the lurah, who's the village head, he wouldn't go up there with a microphone or on a podium. They would sit in a circle, okay? The family, the heads of the family, and the head of the village sitting in the middle in a circle, okay? So everybody sits on the ground. In Indonesia, we have a term called musyawarah, which means, everybody sits around and talks about it. So everybody's, it may sound trivial, but everybody's on the same level. So that's one thing. Just on the question of trust, I'm going to cite the example of how Singapore dealt with the COVID pandemic. And I think most of you know that it's been cited as almost a gold standard in best practices. And there were three elements to the success, and this was highlighted by many people. The first is good governance. They had a centralized system coordinated through various ministries, very transparent, very timely communication, once a week press conferences, openly sharing numbers, etc., etc. So that's the first pillar. The second pillar is obviously health system capacity to deal with severe cases in the early days that ended up in the ICU. But the third one is very telling, social capital. They had a population which trusted the government. There was no burning of masks in the street that we saw in Europe and the US. There was no strong anti-vaccine movement. So that social capital was absolutely instrumental in basically Singapore dealing successfully with COVID. So I agree with you. Trust, absolutely fundamental.
And I remember during the COVID vaccination, the model for the Philippines, looking back, was introducing anticipation. And the way it was done, and everybody didn't know this, was that a prioritization of those who will get the vaccines first. And there was a logic for that because we cannot have all the vaccines we actually needed. So it was rolled out to health workers. The second priorities will be the senior citizens, and so on and so forth. So the anticipation was actually built. So by the time the general public was asked to get vaccinated, and they had so many to choose from, we did not choose one or two particular COVID vaccines, then we had it going. And then someone in the audience here responsible to have the idea of having a national vaccination day. And we had millions vaccinated in a single day. There he is. Thank you.
Fantastic. Well, thank you for attending. Well, I will open this up to the floor, but I think it would be remiss of me not to ask about Dengvaksha. And we were having a conversation before about whether Dengvaksha closure means not bringing it up, which yeah, I'm happy to make a commitment to if it makes sense. But also you mentioned, Dr. Tag, that trust is built on foundations, and it's a case of navigating our way to build and rebuild trust. So before I open up, I would just kind of invite both of you for your reflections on how to have that closure. And I'll cite in particular a study that Prof. Lula mentioned yesterday about vaccine confidence, where I was surprised that the vaccine confidence in the Philippines towards dengue vaccination was extremely high, 85%, I think, which almost tells an opposing story. One might be that there's a sort of potential sense of national victim thinking, or that there is this optimism and confidence towards vaccination too.
Okay. David, to provide a short background for everyone who are here or on live stream, or in this recording, and when you watch this much later, in 2016, the Philippine government decided to roll out Dengvaksha. And the target was more than 800,000 children. And then, just less than a year, the manufacturer decided to change the label because there was some evidence that those who were seronegative and given the vaccine may get serious illness from dengue, get hospitalized, and so they were monitoring for other serious adverse events. But instead of enlightening the public, there was an uproar. And so it became a Dengvaksha controversy. Now, prior to the rollout of the dengue vaccine in question, in 2015, the vaccine confidence was 80%. 4 years later, it dropped to less than 25%. And so the other vaccines, because finally the vaccine was listed out of the Food and Drug Administration list of products approved for use in the Philippines, the other vaccines were actually affected. And so there were measles outbreak and other vaccine preventable diseases outbreak. And then we had to contend just before the pandemic, we had a vaccine-derived poliovirus outbreak. But we had to do a campaign, and you know what? We succeeded in vaccinating so many children with oral polio. So that gave us a resolve that if there was any fallout on the Dengvaksha, we can actually recover. And we stated that this was resilience. And it happened again during the COVID vaccination. We had very high rates. And, but of course, we have not recovered fully because the fully immunized child target is at 90 to 95%, and we barely touched 70, 75%. And so there's still a segment of the population, and we want to find out if these were consequence of the Dengvaksha or there were other factors like supplies, cultural differences, and so on and so forth. And so we don't want to make any conclusions that everything is all about Dengvaksha.
And
This is important
I agree.
because there's another vaccines that has been introduced and approved in 40 countries and actually used in 27 out of these 40 countries, the Takeda's Q-Denga. And in 2023, they applied for its approval from the Food and Drug Administration. They're just waiting for when the FDA gives its green light. I was informed that the Secretary of Health was here yesterday, and I'd like to mention that people in the Philippines may have fears about the vaccine, any vaccine, or they may have fears in case of dengue, fear of dengue. Even physicians are fearful of dengue. They become so anxious every time they get a patient with dengue. So we address these two fears. And I'm even suggesting that we should go beyond the story about Dengvaxia. It, it's near closure. But near closure means that we have to turn a new chapter. Okay, let's look behind it, but not looking behind it without making sure that there were lessons to learn, like being transparent, constant communications to stakeholders, getting the experts, their voices heard, because there's a lot of misinformation.
Absolutely.
And I'm sure in Indonesia, there's also misinformation, Tiki, right?
Absolutely. Let me just make, since David, you were referring to the dengue bugs here. Let me just make 3 observations, personal views on what happened during the Dengvaxia controversy. The first one is that I think the manufacturer, in this case, Sanofi Pasteur, could have been a little bit better in their communications. Okay, they were less than transparent. They had the data, but I guess at that point they didn't think it was important to really open it. So they were a little bit defensive. They were not so open. So I think there was sort of a, I don't know, public relations, corporate problem with communicating the data behind the vaccine. The second one, and I mentioned this during the press conference yesterday, is the role of the media in highlighting misinformation. I told the media, there's a saying that good news is no news, okay? So media in general, I'm not blaming anyone in the Philippines, anywhere in the world, okay? Anything that's sensational, okay, they'll pick up on rather than saying, oh, this is a good piece of news, okay? And because of that, plus misinformation, even among experts. I remember in the Philippines, there's a lady who is the director of your audit department who was quoted in the newspaper as saying 60 children died following dengue vaccination, okay? So the third point is, why did such misinformation actually cause such a big controversy? And to me, it goes beyond just the media and misinformation. It goes to the reality that amongst the general population, there is limited health literacy, and it's actually not health literacy, it's actually scientific literacy, okay? For the lay person to understand that no new vaccine is 100% safe or 100% effective, and there could always be things that you cannot anticipate. That's scientific literacy. So I think that is what is lacking in many of our populations. If they were able to process the fact that this is potentially fake news, maybe it wouldn't have been so bad. It's just my own reflection.
Oh, I completely agree. And it makes me remember that AstraZeneca went from hero to zero during COVID. I mean, we couldn't wait for the vaccine for a while. Felt that 70% efficacy was like, a fantastic during a lockdown period. And then all of a sudden, not miscommunication, but kind of almost a lack of trust or media misrepresentation completely led to that being defunct, which is, but yeah, I'd like to open the floor, and Dr. Naveen, let me invite you to ask first.
Thank you so much. I am Dr. Naveen Thakkar from India, current Executive Director of International Pediatric Association. So my comment and question, I fully agree that community leaders, religious leaders, they are very important, and also the medical professional health workers. My experience with Rotary and also being a pediatrician for 34 years working on polio eradication, we saw that for broader consensus, whether you can take this is halal or not halal or other things, you need a broader, we mobilize as Rotarians many religious leaders. But finally, every family is connected to a doctor, not necessarily qualified, whether he is Hindu, Muslim, or any caste, but he is connected, and he goes to that doctor to verify whether I should take this vaccine or not. We had a resistance in Muradabad, very famous for polio eradication, And we could break that resistance through our pediatrician colleagues. In my Kutch Gandhidham, it's a very interesting story posted on Idea blog on Gates Foundation. My personal story, how we broke the resistance. So in your experience, what is, how do we, if we just focus on, and medical professionals, they have their own questions. We saw during COVID, and you are right that sometime pediatrician will say that this is not, you should not take that, this vaccine is not required, but they have concern and questions. Like in medical, we also went the same way. We first invited health workers to get COVID vaccine. In fact, I was first person in Gujarat to get first vaccine. And there were a lot of people who were raising question, why health workers, why not politicians? And you have to answer that. And but finally, what is your experience here? How to we balance? We definitely trusted voices are important, and do we bring them together? I know there was some efforts during COVID to bring these, even in Gavi, faith leaders and medical professional and scientific community together. How do we deal with that, considering that both are important? And that's my experience from India.
Thank you. Yeah, and I think just to add what you're saying, following religious communication in Pakistan, imams are involved actively to display populations, follow to counter conspiracy. Like speak in Philippines about dengue recently. It's interesting to see how that side outside of government civics as I feel. But Panas, I don't know if you have any reflections or answers for.
Well, I can begin by saying that vaccines do not save lives. Vaccination saves lives. So the Department of Health gets these vaccines, they are distributed, but if it's a mass immunization, communities have to be prepared. It's not just saying, okay, have your arms ready, okay, we'll give you the vaccine. It doesn't work that way, okay? There will be constant communications, there's a core messages, just like I said before. It gets translated to so many languages. Then our village health workers, we call them barangay health workers, will make sure that the message goes to each family. But of course, immunization is a complex process. The vaccine should be available, okay? The vaccinators should be there, the numbers should be reported, the stack out should be monitored, parents should know and follow the schedules. And so the Philippine Foundation for Vaccination, for example, every year works it out with the different medical societies. So we consolidate the vaccine schedule so that it's aligned. But we are also transparent that government has their own vaccine schedule, but that's all right, so that everybody can have a choice whether to follow one vaccination schedule or the other. What's important is that these are reported and there's feedback so that we would know how to improve the vaccine rates. We also get information from time to time on vaccine hesitancy, because we anticipate, the department anticipates that newer vaccines will be introduced, so that when these vaccines are introduced, then all communities are ready to accept it. And especially one of the target audiences for making sure that the message is out there is the media.
Yes.
Okay. And in many surveys, it's the health professional that gets the highest ranking for trust from families regarding vaccines. Just like you said, they go to the health professional, should I get this vaccine? That's the way it is.
Uh, Good afternoon. This is Professor Kobirul Bashar. I am from Bangladesh, working on mosquito surveillance and control. In Dhaka city, not only in Dhaka city, all over the country, as of now, the dengue burden. The highest burden was in 2023, more than 300,000 people are hospitalized and nearly 2,000 people died. So we have pain all over the body. So where we can treat actually, all over the body we have pain. There is an unplanned urbanization, overpopulation, and lot of canned and packet food and plastic cups and bottles. They are producing huge cryptic breeding places of Aedes mosquitoes and high density of the Aedes mosquitoes in the world, I think. And I sometimes said that it is the land of mosquitoes. So many interventions we are trying, but inter-ministerial collaboration is a gap. Ministry of Health and Ministry of Local Government. Ministry of Health is responsible for dengue case management, and Ministry of Local Government is responsible for vector management. So there is a gap between these two ministries. There is a problem. And one thing I want to know from Professor Tiki, there is a Ulbakia. Dhaka is a unplanned, densely populated city, and we have highest burden of mosquitoes in the basement of the multi-story building. The basement, where is the car parking, there is a mosquito breeding. Aedes mosquito is breeding there because the car owners wash their car in the basement. And inside the basement, there's a mosquito, Aedes mosquito is there. So what is your opinion about the Ulbakia infected mosquitoes? Either it will be effective in densely populated, overpopulated city like, mega city like Dhaka. I want to know your opinion. Thank you.
So I guess we have a point about dealing with mosquito breeding sites, and then what project Wolbachia.
Just a quick comment. You're absolutely right. I have been very impressed with the results of the Project Wolbachia in many different locations in Indonesia, in Australia, in Malaysia. Okay, but I perfectly agree with you that there are two issues here. The context is very important. Okay, Dhaka is not Singapore. It's not even Yogyakarta. Okay, and some of the Australian cities. So whether Wolbachia will work in Dhaka, I used to go to Dhaka a lot because I was on the board of the ICDDRB, and it's so totally different. Whether it would work in a locale like Dhaka, that remains to be seen, you know. And the other issue with Wolbachia is how do you scale it up? Okay, it works well under controlled conditions, and it's not a cheap technology. Okay, but so far the evidence is really very impressive. The policy decision is, you know, I think to do more scientific research for other locales to test the viability and feasibility in a city like Dhaka, which may be totally different before you embark on a big Wolbachia program. You know, maybe do a pilot first to see what are your chances of success, because it's expensive to breed millions of these Wolbachia mosquitoes. I mean, the other quick point is enforcement of regulations. Okay, Singapore, very good. You are caught breeding mosquitoes, you are fine, you know, and there's no such thing as bribing the officer to get away. In my country, oh wow, you know, and regulation is there, but if it's not enforced, you have that problem of people breeding everywhere. So I'll stop there.
I have three things. There is a post-summit symposium on Wolbachia tomorrow morning. That's one. Two, regarding vector control and the addition of new tools like Wolbachia, it's always an integrated vector control. No one size fits all. And the third one, use technology, artificial intelligence, short of actually doing a study. So you have these indicators, put it there, and the AI will make conclusions whether Dhaka deserves Wolbachia. Good luck.
Two archipelagos, many. It's such a unique situation where perhaps it would be possible to explore replacement land suppression methods in a controlled manner within both Indonesia and the Philippines. If I were to go to Ministries of Health or Ministries of Environment and suggest this, that there could be both, do you think this could be an interesting opportunity for the rest of the world to see, comparing both within the same country, just to be able to sort of explore different options? What would they look like?
In the Philippines, in our Universal Healthcare Act, we established a Health Technology Assessment Council, and any technology can be evaluated or assessed by that council, so they can give recommendations. But of course, the Department of Health will have the final decision. And there are so many factors to consider, like, for example, acceptability, environmental impact, and all those. And there will be gathering of evidence. But what's sad about this is that there are new technologies, innovation that are already giving us promising results, but on average, there's a lack of up to 7 years before they're actually adopted by so many. And so we lose the fight sometimes. So what's going on out there, we would see that in 10 years more before they actually are adopted. And so there has to be a change in the mindset so that new technologies that gives good promise should be adopted. And there are ways how to monitor the progress, to monitor the possible consequences, positive or negative.
I think you brought up also another important point, the need for better coordination, right? Between Ministry of Health, Ministry of the Environment or whatever. You know, there's a saying, everybody wants coordination, nobody wants to be coordinated, okay? And I'll give you an example. You know, each ministry has its own agenda. The example that I'm going to cite is the Indonesian government attempt to reduce the prevalence of smoking, okay? A former Minister of Health of Indonesia was a good friend of mine, and she told me that every time she gets up at a cabinet meeting and say, we need to do more about reducing smoking prevalence, okay, this is what I think we should do. Minister of Finance will stand up and say, do you know, Minister Nasir, that tobacco tax is 10% of government income? Are you willing to forgo that? Ministry of Agriculture will say, what are you going to do with the 1 million tobacco farmers? Ministry of Industry will say, what are you going to do with the 500,000 people who work in tobacco, cigarette manufacturing? So it's always this conflict of agenda, okay, that plays into it. And from limited experience that I've seen, what it requires, surprise, surprise, is leadership, okay? And leadership not from the minister, but right up from the head of state, okay? In some cases, that's been the deciding factor.
And again, I think credit to Indonesia, HPV and cervical cancer, I think, has been an excellent example of leadership from the top. Yeah, we have a question from the floor.
Thank you, David, inviting for such wonderful discussions. Thank you, Dr. Taggi, and thank you, Professor Tiki. I am Dr. Satish, regional epidemiologist from Sultanate of Oman. Basically, thank you to bring one important questions. In Oman, since 2018, we become endemic. Before that, we have travel-associated cases. Then transmission to 18 to 19, followed by big outbreak. Now we are endemic. And these cases travel associate India, Oman is kind of the mixed population culture. We have Bangladeshis, we have Egyptians, we have Filipinos, we have Pakistani, we have Indian, we have Sudanese. Because 45% populations is non-Omanis who is working there. And we received the turn from travel to endemic case was the first Bangladeshi cases. They have no travel history. Disease come with the body as a virus. Mosquito bite to those people. Mosquito become infected. And this one mosquito, two mosquito bite to the many people. That's how we turn into the transmission. For this one, we are currently working in the one research project. And I'm principal investigator for this project. So we are controlling the mosquitoes and vector patient in Bangladeshis, in Indians, in Pakistanis, in Filipinos, with the mixed culture background. Our experience dealing with each nationality is very different because we came from different backgrounds, different political situations, different financial situations with the personal experience. And on this way, we involving all these other subject around, we choose 888 population. Some cities, some places, area is known like we call that little Indian population, little Bangladeshi population, little Filipino population, little Sudanese population, like that. So we involving their local community leaders and we first build their capacity. We take their knowledge, attitude, practices, how they do. Then we analyze the data. We find the gap exists, develop intervention different for each nationality, and bringing their local leaders, involving them, and putting one alert on every weekend to be involving to bring the alertness. So project is now in the hub of that. We are expecting to finish probably end of the beginning of the new year. So I think as explained and mentioned by Dr. Professor Tiki and Dr. Enrique and David and also from Professor, it need to be combinations. Maybe like vaccinations is there, Olbachia is there, community engagement is also there. So we cannot say which is most first will come. If someone asks me which is important one thing for you, whether your eyes, whether your nose, whether your mouth, whether your ear, we cannot answer. All are essential. But it will be by procedure. So first it can start from community engagement programs involving that sampling evidence base, and later on can be the next step by steps. Thank you.
Thank you so much. I would just like to say, taking care of our brethren Filipinos in Oman. Hope to see you there.
I mean, just to add to that, I think it's absolutely critical, as you outlined, to do the communication and advocacy with those groups which have different cultures, different worldviews, okay, because of their very different backgrounds. And regardless of who you're talking to, basically there are 5 rules of communication and education, okay? Whether you're talking to doctors or policymakers or the media or community leaders. The right message, the right language, the right media, and the right messenger, okay? And it's different from one group to the other. So it's got to be, there's no one size fits all, in other words.
Yeah, totally agree. Anshin?
Good afternoon, Prof. Pangetsu and Dr. Tagia. Good to see you again. Dr. Pangetsu, you talked, Prof. Pangetsu, you talked about leadership a while ago, your keyword. One nation, many islands, both in Philippines and in Indonesia, we see a lot of decentralized leadership. Dr. Eric, when you were the Undersecretary and until now, you've been extremely active going down to the local provinces where we actually see different provincial governors exercising different forms of leadership when it comes to local vaccination programs. From your experience, could you kindly share what you think are the top 3 leadership qualities that some of the LGUs exhibited that will be helpful as we think about the decentralizing and the operationalization of vaccines control? And likewise, Dr. Pengetse, over in Indonesia as well. Thank you.
Okay, I'll borrow it from Tiki, and it's actually true in the Philippines. Political will comes first. Okay, a decision from the highest political leader, like the governor in all of the provinces, okay, will actually make that change. Secondly, the health providers should act in unison so that the messages are brought out there so that the children who will be vaccinated or other target populations get the message and that they have to take care of the misinformation. But it has been the culture in the Philippines that in the provinces, they require national leaders or national experts to help them explain so that they can give better messages. There's always this culture that we want to listen to the experts, to those who really know. But we're sure that in the provinces, there are experts, but they still insist that it comes from at the national level. And so we are stuck with that. And we have so many national experts, and they can actually bring the messages in the provinces. So right now, we have to deal with misinformation. We cannot just let it get away because it's really disrupting any messages that we want to provide to the public. And I want to add the 5th one, the right audience for the communication. Thank you.
So you asked for 3 qualities, right?
He wants 5 now.
Okay, I just give you 3, okay? Humility, transparency, authenticity. Those are the 3 things at the highest levels of leadership. The others, Eric has already added.
So, Dr. Baksa?
I'm Dr. Bhaskar Shanay from India. I'm a president of Indian Academy of Pediatrics, the infectious disease chapter, pediatric infectious disease. When we look at the problems, as you told, there are 2 things. One is vaccination, one is preventing the vector control. Vector control needs more of administrative things, political will. It is a long run, all those things. But for immediate control, we need to look at the vaccination. When you look at the vaccine hesitancy, the situation occurred for other vaccines like influenza, typhoid was different. When influenza came first, the people started asking, is it really necessary? Should I go for it? I heard it is not very effective, all those things. But when dengue vaccine, before it is coming, it has not yet come to India, trials are on. It needs government approval, I mean the regulatory approval, all those things. It will take another 1 year or so in India. People have started asking, when is the vaccine coming? So compared to the other vaccines, the outlook for perception of the public about dengue vaccine is a bit different. So what I feel is when the dengue vaccine comes into the market, it should be taken up much better than what the others. Because in my experience of about 25 years, the influenza vaccine took a long time to become a routine vaccination. But COVID was like a hot cake in the sense people went and even when there was no vaccine supply, they beat and manhandled the vaccinator to get the vaccine. What I mean to say is the degree of severity, degree of the extent of hospitalization, the news of a lot of deaths and disability, all those things, they have created a lot of change. So same with the dengue vaccine. And when it comes to the practice, as Dr. Naveen Thakkar told, the whole system has to be taken into confidence, starting from the administrator to politicians, to the Department of Health, and then the doctors. And also, in India, the healthcare delivery is two system, in the sense, one is by the government directly, free cost vaccine. The other one is by the private, where they have to pay the actual cost of the vaccine. And few years back, there are some vaccines which are not available in the government setup. For example, pneumococcal, rota were not available. And it came to the government setup, and typhoid is not there, which is very common problem in India. Few years back, the health workers who administered vaccine, they used to tell that now it is over, others are not necessary. So they had a hesitancy in taking typhoid and the influenza. But over a period of time, the outlook of those government workers or those vaccine administrators changed. Now they have started telling, see, the basic thing which government gives are over. There are many other things which you should go to your doctor and get it. So the acceptance of typhoid, influenza, chickenpox has become much more. People do come and ask the private practitioner, sir, I have finished those basic government scheduled vaccines. Now I am coming here for. So what I mean to say is that you cannot equate all the vaccines in one way. The take-up or the acceptance depends on the disease, the severity. And also the other thing is, in addition to these healthcare workers and other things, it's the social media which is going to make a huge difference. So posting in social media and other groups would definitely, the advantages of the vaccines and dispelling the myths would play a long way, in addition to media and newspapers or whatever other methods. Thank you, sir.
And that I feel relates to this point about anticipation as well. It sounds like there's quite a high degree of anticipation in India, in fact, which I think speaks positively. I think Dr. Bhaskar is also touching there on health-seeking behaviors as well, and in particular knowing that there is a solution to a problem. Do you feel in the Philippines, Dr. Tag, that dengue is still seen as high priority and high priority enough to want to vaccinate against, to prevent?
Yes, in fact, this month, it is the Dengue Awareness Month. The Philippines is hosting the Asian Dengue Summit. And next Wednesday, there's a Philippines second Dengue Summit. And everybody talks about dengue. And during Dengue Awareness Month, the Department of Health usually reports on a regular basis the number of dengue cases and deaths, so that it can propel communities to do the forest strategies or any new strategies that have been communicated. So that's what happened on the month of June, the Dengue Awareness Month. There are fears for the dengue infection. And in fact, hospitals are preparing that there will be many patients that will be taken care of in hospitals. In fact, last year, we had over 400,000 cases of dengue, the highest in the past years of monitoring dengue in our dengue surveillance. And we are actually looking forward on which particular strains are actually circulating in the Philippines, so that we can predict if the trends in last year will be the same for the next 3 years. And while the WHO has recommended the newer vaccine from Takeda, and this was recommended for areas with high transmissibility, this is not enough for the government, for example, to give its approval, and not because of these recommendations, but because they are considering ramifications of what transpired several years ago and which we discussed earlier. And many are hopeful that there will be closure. So if in polio we are almost there, so here we are also almost there.
I like that. Yeah. Well, in the interest of time, I'm conscious that we've gone a little bit over. Oh, Nick, I don't know if you have a quick question.
I had a question about how do you think we can end the cycle of panic and neglect? It seems when there's an outbreak, people are wanting to be vaccinated, people are wanting to mostly wipe out, but the time when the outbreak is over, then it's like dengue is out of everyone's mind. How do we maintain that sense of urgency even when we're at the downside of the outbreak? Because I think there is this panic, neglect.
Okay, it's a matter of understanding how people behave once communication or message is brought out to them. And so, for example, Peter Sandman's model of risk communication talks about this panic and neglect in some other way. And so if there's panic, you have to calm them down. If there's neglect, you have to stir up emotions so that they will do what they have to do. Okay? And sometimes I remember in our firework related injury prevention, okay, we would change our messages from mangled hands to something that community fireworks display, and we'll get different results. So what it showed us that if we showed mangled hands from the fireworks that caused the injury, many will not light fireworks.
I mean,
But
just
it changes.
Just to add to that, I agree with Eric that this panic neglect thing, a lot of it depends on addressing human behavior. But at the public health administrative level, I'm going to quote, during the APIC meeting in February, we had Sir Ashley Bloomfield, who was Director General of Health in New Zealand during the COVID pandemic. And he said something that really stuck to me until today. To avoid a cycle of panic and neglect, what you have to do is not to have a plan, but to have planning. Subtle difference, plan and planning, okay? So it's about forever being prepared, not just having a plan when there's a panic of an outbreak. So at that level, it's about preparedness.
Again, just brief polio lesson. If you vaccinate now, you prevent summer surges. And I think you can bring populations along with that message to prevent that severe outbreak and cases we don't want to see. Just to conclude then, I'm just conscious of time. One question I feel is very interesting this year is that now Dr. Hebosa is president of WHA. I think there's a really very interesting opportunity to connect north-south, especially as dengue goes up and up. And I hear demand from UK, from Europe, first imported case into Ireland, for example, where dengue is becoming a need for more specialist care there. And I feel like the most obvious answer is to refer to countries where there's that deep decade expertise. So thinking forward, translating this experience that the Philippines has had for decades, from even before DHF being identified here and all that deep expertise, what would be a recommendation on how the Philippines can support the rest of the world in terms of trying to control dengue?
Okay. One of them is right now we're hosting the Asian Dengue Summit. So we better share what has been given to the attendees here, the participants, and that this becomes regular, and that each member state are able to share their experiences and knowledge. And well, the Philippines is not only a tourism destination. Maybe we can do something about experts coming here to know about
Absolutely.
dengue.
Yep.
Why not?
Prof. Timmy, I think will try to lead
Yeah,
on this.
especially we are anticipating the introduction of the new dengue vaccine, then we can share more information.
Just to quickly add to that, I think take it to the next level. With what's happening globally, especially in the United States, I believe the future is about regional leadership. Okay, the example of the Philippines, for example, through ASEAN, okay, bring together all the countries in the region to share experiences and mobilize perhaps an alternative model of global health governance that's more regional, more inclusive, more fair, more equitable. That I see this as the future.
Fantastic. Well, thank you both so much, and thank you everyone for coming to listen to this fireside chat. Extremely interesting and thought-provoking, I think. So yeah, big round of applause for our...
Thank you, David. I survived without having to dance. Thank you. Dr. Achansa, thank you for those national immunization days. Okay, for COVID. Thank you. Thank you,
so much.
everyone.
Thank you, everyone.
Thank you.
Okay. Enjoy the rest of the sessions today.
Thank you so much.